of the Trust, and our first meeting of the year, so Happy New Year to people who I haven't seen. But also in terms of apologies for absence, I just wanted to highlight we've had an apology from Elaine Hay for this morning. Also, I wanted to welcome on this call, we have Tasneem Arshad, who's observing as part of the reciprocal mentoring programme. So welcome, Tasneem. Also wanted to welcome Alicia Jones, who's here as an NHS graduate trainee who's observing this morning's meeting. So welcome, Alicia. And again, I wanted to finally welcome Jennifer Hart-Prager, who's the board committee clerk. This is her first meeting. So welcome, Jennifer. Great to see you. Okay. In terms of declarations of interest, I'm not aware of any declarations of interest. Nothing's been brought to my attention. So I'll move on now to the minutes of the last meeting that was held on the 30th of November. And again, just really wanted to bring colleagues' attention to points of clarification, accuracy, because I'm not going to go through them page by page. So if there are any comments, changes, let me know. Otherwise, please confirm, I can't see any hands up, that you're happy to approve the notes. Okay, I can see lots of nods ahead, so I take that as approval. Okay. In terms of the action log from the meeting of the 30th of November, that's in the pack, and the action that's pertaining to later on this year is noted as well. Okay, thank you. I don't know whether any comments, queries at all. Can't see any hands up, so I'll just move on in terms of the next part of the agenda. Looking at matters raised by the Council of Governors, we've had no matters raised for this meeting and no questions asked of this meeting. So I will, and obviously that's a running part of the agenda as we go forward, so I will move forward to the next part of the agenda, which is the Chair and Chief Executive's updates. And as the Chair, my update, I'm just going to provide just some headlines, not detail in terms of everything I've done over the last month or so, but just some highlights really. I just wanted to highlight that I'd visited the Gambling Harms Clinic based at Cobridge. And again, for me, that was a great opportunity to meet and hear from the teams about the service and also about some of the specialist therapeutic support they provide to people with gambling addiction, gambling problems across Stoke, Staffordshire, Telford and Wrekin. It was fantastic to meet the team and to actually hear about some of their experiences, look at some of the data, some of the information and things that they're doing. A really, really positive approach. I also wanted to highlight that I chaired the interview panel for the consultant in genitourinary medicine, HIV and sexual health during December. Again, we had good candidates and we were really successful in appointing to that post for a consultant to cover the Stoke and Telford areas. That was really positive. Again, as part of my role, I attend the Combined Medical Advisory Committee and just wanted to highlight for the December meeting, I gave them an overview of the work that we're doing in terms of the governance structure. That was welcomed in terms of understanding our committee and board governance, but also it was an opportunity for me to actually really acknowledge and thank the team for the work that they're doing, but also the success they've had in their Keele Health and Care Awards, but also in terms of their work being proactive in terms of providing safe and effective care for our patients throughout the course of their work during the year. So it's great to actually have that relationship and that opportunity. Also, I attended the Staffordshire County Council Cabinet to Trust meeting, which really focuses on our progress against the Section 75 agreement. And again, really positive. Again, things are working really well. It's a great partnership. But also, as part of that partnership, I have a regular one-to-one meeting with County Councillor Julia Jessel, who actually chairs the meeting and is a social care and health portfolio holder. So again, I think that's really useful in part of our relationship with Staffordshire County Council. And again, the other thing I wanted to highlight, as other members of the board, I'm participating in the reciprocal mentoring programme, which is an 18-month-long programme, as people know. We completed the second module in January, earlier this month. But also, I think I wanted to highlight, as a chair, I'm really proud to be part of the programme because it's been a great opportunity for us as board members to develop that one-to-one reciprocal relationship with staff, but also to hear what their experiences are working for us and with us. But also for me, there's something about our genuine commitment, which we've highlighted in those meetings, about being responsive to some of the themes that arise, and actually being responsive in a timely way, not waiting for the duration of the programme before we respond to where we can. So those are some of the things I've been involved with. And next month, just wanted to highlight, I'm looking forward to meeting the Arts for Health team, but also attending and opening the Trust Suicide Prevention Conference, and again, attending the digital fair that we'll be hosting at St George's. So just some summary from me, but happy to take any comments, questions as usual. Thank you. Okay, are there any comments, questions, queries? Thank you. Okay, so now if I can invite Neil to take us through the Chief Exec corporate report and update.
Thank you, Chairman. Thank you. I'll attempt to up my game, given the fact we've got Alicia here as a management trainee, just to make sure we're on message. Couple of things before I go off piece that I just want to share with the board. Professor Zafar Iqbal, who you know is one of our associate medical directors, also a consultant in public health, and if you go far enough back, a general practitioner, he is able to attract almost magnetically some of the best thinkers in the West Midlands who are doing the aspiring public health consultants course. They all came together with us as a senior management team at the beginning of this week. And it was enormously impressive, the range of activities they're involved in, which is really challenging the way we develop our strategy, the intelligence they're bringing back to inform our strategy, and how we're deploying significant change. I actually thought they were giving brilliant examples of the diversity of their work, but how they're making a real impact to patient care. I think it will be something the board would benefit from, a discussion with those colleagues and Zafar over the next few months. But if any of you have the opportunity to bump into Zafar or his team, great opportunity for you to learn some of the detailed work they're doing, and I hope other colleagues agree with me. On a similar vein, you know, long gone is the notion where research, development, innovation is seen as the icing on top of the cake. If we're not researching, if we're not developing, if we're not thinking the fundamentals of the pathways, then we're doing nothing. And again, through Abbott's directorate, Ruth Lamley-Burke, Professor Christian Mallon, Professor Carolyn Chew-Graham, Professor of General Practice in Public Health and in General Practice, and Professor Saeed Farouk, who's doing a lot of international work. They led discussions, but there was also a number of our doctoral students presenting their work on their journey. And for the couple of hours I was able to sit in on that, I think we should be very, very proud of the fact that we're talking a lot about transformation, but what they're doing is having a look at how that's deploying in practice. How are we remaining effective? How are we remaining responsive in terms of patient care? Again, I'd commend you to Ruth Lamley-Burke and her team around some of that work. Again, can I sort of talking about some of the key lines of inquiries that the Care Quality Commission will be interested in? You will have seen all sorts of notions from the CQC over the last period of time. The one I'm particularly interested in is what was published by Newcastle, Tyne and Weir a few days ago, where they've gone from outstanding to requires improvement, as I understand it. A lot of that was around culture, behaviour, etc. And again, I think it is something that we can be proud of at the culture and how issues are deploying here. It's becoming a growing issue, and if things are going wrong, in my opinion, it's in the name of not getting the right behaviours, the right values deployed. So I don't think we can see those issues as pink and fluffy. I think we've got to see them, frankly, as absolutely fundamental to delivering safe, caring, responsive, effective, well-led services. The other thing that's slightly disappointing, and Dr. Khan might want to correct me, the BMA consultant vote closed, I think, over 24 hours ago. I was fully expecting the consultants to agree for industrial action, further industrial action. But Abid, I've heard nothing either through formal networks or through News at 10.
No, no, Neil. BMA's vote has not been announced yet. It finished at midnight on the 23rd, so they are probably counting and reflecting before they make an announcement. But we have got the result from Hospital Consultants Specialist Organization, which is the smaller union compared to BMA, and they have rejected the vote by 58%. So the offer was rejected by them. We are waiting for the bigger union, which has got 10 times more membership, to come up with the outcome.
Yeah. Thanks, Abid. That's really helpful. And I know it's something that Abid and his team are alive to. But I think the group that you've talked about who voted in favour, they've only got something like 2,000 consultant medical members in total, Abid.
That's correct, Neil. There were 2,000 compared to BMA, who's got 30,000. So BMA, whatever they decide, will probably be the one that we need to know.
Yeah, thank you. Chairman, if I can take you to my corporate report then. Page 3, absolutely delighted. It's been a long time in the making, since 2019, but we have followed all due process regarding our services, inpatient services out in Tamworth, and the decision was formally taken at the Integrated Care Board at its last meeting that we see the permanent closure of the George Bryan Centre. That has now gone through due consultation with the public, due process, and that is now a done deal. I think board will be aware, but it's worth just pointing out many more older age adults that would have been requiring of inpatient care are now managed effectively in the community with enhanced services. If patients need to come into hospital, there is capacity on Bassage and Bromley ward for older adults requiring inpatient care. And you'll recall that Milford ward at the point of the arson attack was recommissioned with the staff of the George Bryan Centre to allow inpatient care flows. One of the things we said we would need to manage over a period of time is that relatives could continue from Tamworth to visit, particularly if they had limited travel arrangements, etc. To the best of my knowledge, there's been no issues there, and it was a unanimous decision on the part of the ICB to see formal closure of the George Bryan Centre, which I think is helpful. Moving on, it's great news and work underway to develop new 4.8 mental health assessment centre on the St George's site. If any of you have been over to the Education Development Centre, you will see a lot of building work at the far end. It is progressing well. I think the way I remember it, it's the equivalent of an accident and emergency department for people in mental health crisis, but it will be available 24 hours a day, 7 days a week. It will be able to make sure we don't follow restrictive practices. It will have 2 136 facilities attached to it, and I think it will be well resourced and well staffed. And I hope it will be a useful facility for all health professionals, but including people like the ambulance service and the police that might want people assessed. So that's good news, and I think it'll be up and running next year. Work certainly seems to be progressing well. If I can take you to agenda item, enhancing provider collaboration across Shropshire, Telford and Wrekin. They have now established committees in common. As you know, we took the decision that we would be affiliated members. Richard has been working hard on governance with the system. I think it's important that we are seen to be good partners to them, but I think we also have to recognise the way the integrated care systems, the 42 systems, are engineered. Our main activity, certainly financially, will be with the Staffordshire system. So we have to find very legitimate ways of engaging both with the integrated care system and with the providers as part of the collaborative. And I think through the good graces of yourself, Jackie, yourself, Pauline, and with a little bit of help from myself, I think we're managing to get that right. But we need to continue to explore what does getting our relationship like in Shropshire look like, and maybe in the confidential section we can talk a little bit more about that. One of the things that I was really excited about regarding the committee in common in Shropshire, they've agreed on 4 priorities, as you can see: urgent and emergency care, no surprises, musculoskeletal, real issues between the Robert Jones and Agnes Hunt and SAF, and how do they square some of those issues, workforce. Alex could talk ad nauseum about the workforce issues in Shropshire. It is difficult, it is complex, but the one I particularly want to highlight to board members, the committees in common agreed very willingly to establish mental health in terms of children, young people, autism, etc. And I think that's to be welcomed, and we will continue to drive that forward at pace. Again, just sticking with the Shropshire agenda, colleagues will probably be aware that the full business case has been accepted within SAF for the redevelopment of their acute services. I think there is now an agreement that Telford hospitals will take on more of a planned care facility, and that Shropshire will take on more of an urgent and emergency care nature. And I think that's something that MPFT could certainly get behind. Again, if I can just take you to point 28, NHS equality, diversity and inclusion. There is correspondence from the centre being very clear how we have to improve as systems, not specifically MPFT, around equality, diversity, inclusion. I had a meeting this morning with Baz, and as far as I can see, Richard and his team, Baz, have been working on a new strategy. I think that's going well. I think that will be leading the pack. I know Baz has been discussing that within Shropshire as well as Staffordshire. Paul Draycott, the Director of Workforce in Combined Healthcare, has the lead for this agenda, and I know people like Richard, Baz et al. Are close to it. Richard, I don't know if there's anything you just want to highlight as we take our journey to March 24.
Yeah, thanks, Neil. So as you rightly say, we're kind of well into the midst of developing our EDI strategy. The plan at the moment is that will be coming to kind of the board for development during February. Hopefully on a journey for it being formally approved by the board in March. I think there's been some really exciting work which has been taking place on that in the background, both engaging with staff to understand what's important to them, as well as going out and engaging with local communities as well, so that they feel that they're really kind of informing the direction of travel. I guess the other point to pick out, Neil, which I'm sure came up in your conversation with Baz this morning and is referenced in the report, is there's a requirement for all board directors to have a specific objective, which is around EDI. So we will be doing some work with Neil and with Jackie over the course of the coming weeks, just so we can make sure that we're compliant with that, and all board members have got that objective written into their plan for the year.
Thanks, Richard. Jackie, I'll move at pace if I can, yeah. But point 29, meeting the needs of autistic adults in mental health services. There's been a legitimate spotlight shone on neurodiversity in the NHS over the last 2 years. 10 principles have now been established as to what good practice looks like. And again, I'm delighted that the managing directors and their teams are alive to that and driving that forward. And in a similar vein, offender personality disorder pathway, a lot of work needs to be done around that area, both within Howard's team, people who are subject to prison sentences, but also people with mental health and convictions who are being cared for as part of our mainstream services. There is more work to do to ensure that those individuals receive best practice mental health care, and that's contained there in terms of the offender personality disorder pathway. That, Chairman, is where I will stop. Happy to be challenged, try and give clarification, or move on.
Thank you, Neil. Thank you. A really comprehensive update. Are there any comments or questions for Neil on his report? I know some of the items are picked up on the agenda. Abid.
Hi, Chair. Thank you very much. I just wanted to highlight the importance of culture and the openness of not just the board members, but also the governor members and care groups who personally interact and visit services, because that is the way to get first-hand feedback as to how, and your attendance at the consultant body meeting, the joint consultant meeting, you can assess firsthand. There are no filters. People can talk to you about anything. And I think when you visit services, it's important that we pick up on culture, because I think all the care groups are very open and we all try to be accessible to people. But the importance of culture is reflected in the well-led issues that Newcastle faced and had such a big drop. So I welcome the engagement from the board to our staff during not only the visits, but also at the meetings. Thank you.
Thank you. Thank you. I think a point well made. That's really important. Thank you, Abid. Are there any other comments for Neil, questions? Okay. So now I'm going to move on the agenda in terms of the governance and risk reports. So if I can move on to the board assurance framework, which Liz is going to provide us with some highlights. Thank you.
Morning. Thank you, Jackie. Firstly, I just wanted to start by acknowledging the work that Rob Grant, our Associate Director of Safety, Risk and Compliance, has done in terms of particularly aligning the strategic risks across our board committees, but also this new style BAF report that we see at board and we are now seeing into our committees. So I just feel there's an incredible amount of work that Rob has done to get us to this place. There are just 3 areas I wanted to report on from the board assurance framework. If I could start with the Integrated Business and Performance Committee, you'll note in the report that there are 2 new strategic risks aligned to that committee, risk IB09 and risk IB10. Those 2 risks actually combine a number of other risks that were stated on the strategic register, and it was felt that those needed to come together into 2 overarching risks that really focused on the changing business and the competitive landscape we're in, and also some of our estate's challenges. Just to note that alongside these 2 strategic risks, there are a number of specific operational risks in the risk registers that our operational managers around this virtual board have ownership and oversight of. So the Integrated Business and Performance Committee will continue to monitor those 2 risks, and a summary of progress against the actions will come through in the highlights report to board. In terms of that risk, just on page 37 for risk IB09, you'll note that there are 9 key actions associated with that strategic risk. There are obviously timeframes set to April to actually mitigate the risk through those actions. So I think a key reporting timeframe back to the board will be April, once we've had further assurance against those actions. And with IB10, which is on page 41 of the pack, you'll note that there are 5 key actions to further mitigate that risk. One of those actions is complete, and it relates to the work done on the estate strategy. There are 4 actions to note. You'll note they don't have timeframes for completion against them. That's because the work to pull that risk into one has only just happened. So the Integrated Business and Performance Committee will be setting the appropriate dates for mitigation of those actions in due course. The second area I just wanted to highlight was from the Quality and Safety Committee. There had been a strategic risk, QSO4, around compliance with CQC and maintaining compliance at good across the organisation. We had a deep dive review of that risk, and the committee felt that this risk should be stood down. Not necessarily, although important to note that we have maintained good as an organisation for a number of years, even though we've had recent inspections, we've still complied at a level of good. But what the committee felt was there were more specific risks on the risk register on the back that gave us that indicator of whether we were meeting CQC compliance rating of good, and that this risk in itself didn't do that, and the mitigating actions associated with this risk couldn't maintain that. So a decision was made to stand that risk down, but noting that the business of the Quality and Safety Committee and the risks going into that committee would absolutely be the temperature check of compliance. And then finally, the People and Culture Committee have had further discussions relating to their strategic risk appetite, given some of the changes actually in our financial and regulatory scrutiny. So they are going to do a full review of that risk appetite during February, and we will report that back to the next board as part of this report. You'll note from the paper just finally that it's been condensed, and we've reported the detail only of those risks that I've just cited there in my oversight report. The rest of the detail around the strategic risks are contained within the reading room, so are available to board members. So I'll pause there, Chair. Happy to take any questions or comments.
Thank you, Liz. And can I just say thanks? It's a much easier to read document. It's much more streamlined and very focused. So thank you. Debbie, if I can bring you in for a comment or question.
Yeah, yes, thank you. It's a comment, I think, really. I completely concur with Liz's, the work that Rob and Liz and team have done is really, really good stuff. I just thought I might as well do it now, Liz, rather than in my report. Just to note, the Integrated Business and Performance Committee have added a new risk regarding performance, which there's some virtual email stuff going on around performance, so that will come through in the next report. I think the main piece was it's as part of the actions to be considered by the board bit of my report that I think we've done tremendous work, and I think the committees are really embedding well now with the new BAF. But perhaps it's time now to come back together to review the risks in the round, to really consider that piece around appetite and tolerance, and to really kind of be clear about the assurance piece. It's that consistency now, Liz, that across committees, and I think the job of the board, we can see that in the round together, can't we? So that's the to be considered by board, really. It was one of the pieces that came out of the Integrated Business and Performance Committee on Friday. So thank you.
Thank you, Debbie.
Just in response to that, if I may, and obviously I'll look to Richard for a view on this. I mean, previously, although this is a live process and set of documentation, previously what we've done as a board is have an annual review of our appetite and consider the risk together, and due to the time allowed in the public board, we've done that as part of our board development. So my proposal would be that we agenda that into a board development session, so as we've got enough time to have those joint discussions and set the right appetite for the board going forward, but also, yes, that alignment and greater consideration of those risks in the round.
Thank you, Liz. I would support that as well. I know we normally look at them in the round, but I think a board development to look at that would be appreciated. So thank you, and we'll note that. Richard, if I could bring you in. Hi.
Yeah, thanks, Jackie. Morning, everyone. So just on Lizzie's point there, just to reassure people, Liz is absolutely right. It is considered best practice that we undertake a review of our risk approach, our risk appetite and our tolerance at least annually, and we do normally do that in board development space, and that is kind of on the forward plan for this year. Just kind of a couple of quick questions from me, or maybe kind of points for clarity, if that's okay, Jackie. So the first is in relation to the Summary Board Assurance Framework, the risk movement diagram, which is on page 34 of the pack, which is really, really interesting, actually. I just noted on there, Liz, that some of the risks seem to suggest that they've not been through an assurance assessment for kind of the best part of 12 months. So I just wondered if we could be confident that the new risk operational group, which I know Rob is in the process of setting up, will help ensure that there's kind of more regular reviews of those assurance mechanisms. And then I guess if I may, the second point for me is just in relation to the new risks which have been added, IB09 and IB10. And I would have raised it Business and Performance Committee, but I wasn't there this month. I just wonder whether they need a bit more specificity in describing the risk. Both of them seemed quite vague, so I just wondered whether we might need to drill down into them a little bit to really articulate what we think the real risk is there.
Yes, I'll take the latter point first. I think that is something that, yeah, we can and need to consider, and I would suggest that's best placed within that committee. I think they're the experts in that area and the best place to ensure that the description of the risk is accurate. The first point you made about the diagram on page 34, it isn't that those risks haven't necessarily been through that review. We have done a deep dive review of all of our risks. Some of those risks are newer risks, so they weren't actually, so at Q1 and Q2, they weren't actually live risks at that point in time. But you are absolutely right. The purpose of the new risk and compliance group is so that operationally we can come together as senior leaders to do that piece of work in more detail than we would have opportunity to do through the committees, and therefore the committees would receive the outputs of that work that we're doing in that group, and likewise it enables us operationally to escalate through to DMG any of those areas where actions aren't necessarily getting the traction, or that we feel there's a deteriorating picture in terms of the management of that risk. So we're really, that group is just due to meet actually its first meeting, and we've got a terms of reference set. So hopefully the board and the committees will see the outputs of that group very soon.
Thanks, Liz. Thanks for the clarity. Thank you. Are there any other questions, comments for Liz? Okay. I just wanted to thank Liz, and also to extend our thanks to the work that Rob Grant has been doing as well in terms of reframing and shaping how we do this. And it'll be useful to see how that kind of frames or pans out in terms of the risk group that's been developed. So thank you, Liz. And again, in terms of the report, we're being asked to note the report, but also to approve the closure of the risks that you detailed, IBO1 to IBO2, IBO7 and 8, and approve the new strategic risk, which we know is going to be re-articulated as well. So thank you. I'm now going to move on to the next part of the agenda, which is looking at finance, performance and quality. So if I could ask Chris to take us through the highlights from the finance and performance report. Thank you.
Thanks, Jackie. So in terms of the finances, good news at month 9. We're on track to deliver against our break-even target. So we've got surplus of 1.5 million at month 9 against a plan of £1 million, and we're forecasting that we've forecast a surplus of £1 million at year end, which gives us a bit of headroom in terms of our break-even target, which is great. We've in our submissions to NHS England this month, we have included now the impairment for the RAC scheme at Haywood, which was a risk that we flagged in previous months. Touch wood, we've not had any feedback from NHSE on that, so hopefully they agree with our accounting treatment. So that's good. We'll wait and see what comes back. Just to flag, we've seen an increase in agency this month, which is probably not a surprise given sickness levels over the winter period and the escalation capacity that we'd need to put in place. But that's an area we just need to keep our eye on. We are below the cap target, which is again good news, but just an area to keep an eye on. From a system perspective, we've now been through the process, which the board will be aware of, agreeing our forecast outturn position with the national team. So for Staffordshire, we've finalised a position of £91.4 million deficit. And I think the latest on that is that we're fairly confident that we'll be able to hit that 91.4. Now, the 91.4 is before the impact of any further industrial action. So there is a little bit of flexibility there, but we should be on track to deliver against that. Within Shropshire, they've had an agreed deficit position of just under 130 million. Again, there's probably a little bit more challenge in terms of delivering against that position in Shropshire, but that's the position. And I think much of our focus now from a financial perspective is looking forward to 24-25. So it's a joint executive event that happened yesterday, started to look at some of the opportunities around how we address some of the financial challenges, and we'll continue to work on that over the next couple of months. Then just moving on to the performance report, we bring the exception report to the board. The detailed report has been through the Integrated Business Committee that met last Friday. I'll not go into the detail. I think I'll just open it up for questions on either the finance and the performance now.
Thank you. Thank you. Okay, are there any comments or questions for Chris in terms of the finance and performance report? Any comments, questions? Jane?
Hi, Chris. I know some of this we've rehearsed actually in IBP, but can you just clarify if there's any implications from the current situation with local authority budgets?
Jane, we can't hear you. I think she might have dropped out.
Yeah, I think we've got most of the question though. So yeah. I think clearly the financial climate that we're operating in is getting more challenging, both in health and both in local authorities now. Clearly, as things get tighter, then we all have to make some difficult decisions, and we have to be really careful about the unintended consequences of those decisions. So we recently got the budget proposals from Stoke City Council, so we have had a look through those, and we have done some work around a risk assessment in terms of how that might impact on us. That there are risks, I think, from local authority positions, but there are also opportunities, because when things do get tight, then there's an incentive for us all to work together and to look at where we can do things jointly. So it was good to see that both councils were at the event yesterday and are fully engaging in that work. I think it's important that we're open and transparent as a health service and local authorities, and we share the plans that we're intending to do, and we get into good debates around how do we make best use of the pound for the local residents.
Thank you, Chris. I don't know whether Jane's back on the call. I can't see. Debbie, you had your hand up.
Yes, thanks, Jackie, and thanks for a really clear and succinct presentation, Chris. We have had a thoroughly good chew over this at committee last Friday, but I just wondered if there was an update on the work of the system, Chris, because as you say, at this time of the year, we're making sure we deliver what we said we'd do this year, but our sights are focused on the next financial year, and we know that that's tough. I just wondered have there been any further system discussions regarding, schemes, what the plans are potentially to close that gap next year, Chris, since we met, really?
Yeah, so we had the system event yesterday, yeah. Debbie, and there was, I think, 6 or 7 groups that were looking at different areas. I think that needs to be collated, that needs to be fed back to chief execs and other colleagues, and I think out of that we need to then put our colours to the mast in terms of what are the things that we're going to focus on. There was also an interesting discussion about how do we prioritise better, because sometimes we try to do too much and then don't deliver anything at all. And I think that there will be something about what are the 3 or 4 big things that we're going to focus on. We've still not had the planning guidance issued, and I don't think that's going to change anything. But it would be helpful if that would be issued. But I do think it's going to be a busy couple of months, so we'll make sure we bring an update through IBP in February, and then we'll bring that through to the board, so the board's kept abreast of what's going to happen.
Thank you.
Thanks,
Thank
Jackie.
you. Thank you. Thank you. Simon, you've got your hand up. Hi.
Thank you, Jackie, and thank you, Chris. Chris, sorry, I probably just missed this, but I think you said that the system, NHS England had agreed the system deficit of 91.4 million, which is the number I had in mind. But then in the overview paper, you refer to 93.3. I wonder what the difference was.
It's probably the impact of industrial action. So what the agreement is with the national team is it's a deficit of 91.4 before the industrial action of December. Okay. So the sort of the cost of industrial action, once confirmed and challenged with NHSE, is a sort of an allowable additional overspend.
Okay, thank you.
Thank you. Thank you. Alex.
Thank you, Chair. Good morning, everyone.
Morning.
Just a quick comment, if I may, just to say that from February we've agreed, Chris has already alluded to the challenge around agency, and we had a good debate last time around workforce growth and the workforce position. So you'll see that starting to come through in the report from February in greater detail, so that we've got greater oversight, but also we've got some transparency. Obviously, that scrutiny is going to get greater over the year, so you'll see it starting to come through. Just wanted to make you aware. Thank you.
Thank you. Thank you. Neil?
Thanks, Chairman. I'm going to ask my question, Chris, through you, probably to Claire, but I know in the introduction to the performance section, there is an issue on paediatric audiology, which I know has been an issue. And I just wondered if we could have the 30-second update, Claire. Are you content with how that's moving in terms of our responsibilities?
Thanks, Neil. So the bronze cell is still in place that's monitoring the delivery of actions against the recommendations from the report and the external review from NHSEI. And I have to say the collaborative working across partners is something that we really need to credit, and they are going to be supporting us in terms of our waiting list initiative. We are in a much stronger position, Neil. When I say stronger, I mean in terms of through the support of the audiology team, QI team, digital, working together, we've been able to now validate waiting lists. We've got automated reporting. We know exactly what we're dealing with. We're able to really refine the waiting list into cohorts based on acuity. So there's a real grip around that. And we're now just starting to look at launching the waiting list initiative in order to bring those children within the timescales that we would want to bring them in. And just to assure you that by February, the highest acuity, it's called D1 and D2, they will all be within timescales by February.
Thank you, Claire. Thanks for the assurance. Jane, you're back. Sorry. Hi, Jane.
Oh, hello. Sorry about that. You might have gone ahead and carried on with my question. I'm not sure.
I think we did, because Chris actually got
Fine.
the whole question. Yeah.
I'm catching up with Chris later, so I can catch up with him then. Thank you.
Brilliant. Thank you. Thank you. Are there any comments, questions, any further ones for Chris? Okay, I just wanted to thank Chris, really comprehensive update, and I think concise as well. But also, I also wanted to thank Claire in terms of the assurance, because audiology was one of the things on my radar of concerns on performance. So thanks for the assurance in terms of where we're likely to be in February. So thank you. The next item I have under this part of the agenda is the quality report. So if I can invite Liz to just take us through some key points on that.
Thank you. So 3 areas I wanted to draw out of the report, if I may. So point 2 of the report, focused inspection for wards for older people. CQC did a focused inspection in November last year. We are, as of today, awaiting the publication of that report, the publication date being tomorrow. and because it's embargoed, it wouldn't be fair at this point to report back the findings in detail through to the public board. But what I can say is it is a positive report. It was actually a pleasure to read in terms of the positive strands that flowed throughout that report. Both our comms team and the CQC's comms team have prepared statements which will be released tomorrow alongside that report, and we've also prepared briefing which has gone out to our staff, or will go out to our staff today, and stakeholder briefings as well. The only other point I wanted to make about that, which I think is really key to point one above, which was the acute ward and PQ ward inspection that happened the previous year, was in that report and in the initial feedback we had following that inspection. It was noted by the CQC inspectors, the learning that we'd taken following that acute and PICU review, and how that was evident that that had been shared with the older people's ward, and that they put in place measures linked to some of the findings of that previous inspection of the acute services. The second part of the report I just wanted to highlight was the Green Annual Report 2024. This went to Quality and Safety Committee and had a full delivery of that annual report and feedback from committee members. I don't intend to go into any great detail, and the full annual report is in the reading room rather than in the pack of papers available here. We're really doing positive stuff in the green sustainability space. We're above and beyond our plan and what we expected to have achieved at this point, and we are on target to achieve by 2025 all of those areas, both nationally and locally, that we need to achieve around our sustainability agenda. And then the final report to draw your attention to is the Learning from Deaths review. Again, that full paper is in the reading room, but you'll just note within this summary report some key learning that's been drawn out of those Learning from Death reviews. I think what we're starting to see now really is the implementation of PSERF, the Patient Safety and Incident Response Framework. We're undertaking different style reviews of deaths and other incidents that occur, some real rich learning happening at team level and with people involved in the care of those individuals, and that is starting to filter through into some of this wider learning that we are sharing across the organisation. Those are the three areas I wanted to pull out of the report, but I'm happy to take any questions or comments.
Thank you, Liz. Thanks for a really concise summary and update. Thank you. Got a couple of hands up. Neil, any comments, questions?
Thank you. It's an observation, and I address it to Liz, but I'm conscious Kathy was a chief pharmacist, and we've got a chief pharmacist in Dr. Campbell we can ask. But the last few CQC reports I've read don't talk about must-dos as much as should-dos when it comes to the safe storage of medication and temperature control. And I just wondered, Liz, do we feel we've got a real handle on that? Because to me, is it becoming a bit of an Achilles heel? I know that's a detailed question, but it's a very legitimate question in my opinion, Chair.
So in terms of the must-do versus should-do, the reason that it would, and it does come out as a should do, is because the CQC haven't seen that there's been some systemic issue in terms of that. It's a specific thing that they found in one part of the organisation, so one ward. In the case you're referring to, temperature in fridges. From an assurance perspective, and I'm talking on behalf of Andrew, and whether Abby or Kathy want to come in, we do have regular and routine audits of a number of specific areas about storage and administration of medications. On the back of those audits, of which we do find areas for improvement, there are actions that are managed both through the pharmacy team and operationally, and are reported through P+. So my view is that we do get a handle and a grip on some of those areas around administration and storage very quickly, actually, and we haven't got any systemic problems across the organisation. They tend to be specific and contained to a ward or a part of the trust.
Thank you. Kathy, did you want to come in, or is that what you've got your hand up for?
It was just to concur really with what Liz just said,
Yeah.
but also to say that there are digital innovations that can help ward staff with regard to that I think it would be useful for us to explore across the trust, because we are probably quite old-fashioned with the way that we are doing that at the moment. That was all I was going to add, Chair.
Thank you. Thank you. Okay. Richard, if I can bring you in.
I think Debbie was before me, Jackie. I'm happy.
Oh,
to
sorry,
defer to
Debbie.
her first,
Sorry,
if
I
that's
missed
okay.
you.
It's fine. Don't worry. I'm happy to wait. Richard, go on. Off you go.
We're being too polite to each other, aren't we? So I guess my question is directed at you, Liz, but maybe Kathy and Jenny might want to come in. So I guess what I'm interested to know, I thought the stuff in there around the CQC and the adult acute mental health wards was really interesting and really reassuring. I guess what I was keen to know is, obviously, if there's an action plan and actions are implemented and they're monitored, that potentially represents a point in time, doesn't it? So recognising that the CQC could knock on the door at any time to do a re-inspection, how do we continually kind of reassure ourselves that we're on that journey and that things aren't slipping back inadvertently?
A really good question, and I can answer that, and Jenny, Kathy might want to talk about the measures that are in place in the care group. But one of the things that we do is we both ensure that we've got the right audit approaches to enable us to continually monitor some of those areas. So, for example, from the acute wards inspection, there was an area about how we manage at-risk items. We've got a process of audit in place that's done by the audit team, but also through the matrons that are there at ward level and observing and viewing that on a regular basis. So audit is one way. The other way we do that is through regular visits to teams. So as you know, we've got our QSAB visits. When we go out and do a QSAB visit, we take the information specific to that particular area. And when visiting the acute wards, we would take forward the information from the CQC inspection to ensure that's continually being embedded across not just those wards, but across any of those service areas where we think there is an alignment with those service areas. And then the third point I would say, particularly from an inpatient perspective and from a nursing perspective, is the roles of the matrons and the quality leads across those service areas. So those two groups of staff on a day-to-day basis and feeding into the matrons and ward managers meetings have oversight and checks, written down sort of checklists that they use to enable them to see that there's no slip in terms of compliance against the actions we agreed to take. But I don't know whether Kathy, Jenny, there was anything you wanted to bring in from an operational perspective. I mean, we've got, multiple monitoring systems, haven't we, both through the quality subcommittees in the care groups and up to our quality and safety committee too.
Chair, do you want me to just respond?
Yes, please.
Just to say that there are multiple monitoring ways, but also as we walk the wards, we see the complete change in practice that's embedded. So I feel quite assured around it. There's been a big change in practice that is there and very evident when you walk the wards, but there are also lots of assurance audits and things that take place on a weekly basis.
I think, Jackie, if I may, whilst we're on that point, yes, before Debbie and Abby come in terms of the acute ward inspections, and you'll note that it says that 79% of the actions are complete. If board members were wondering at this point, 12 months plus down the line, why we haven't completed all of those actions, I think I'd like to draw back to what we were saying about the culture of this organisation and the proactiveness of our staff. We have completed all of the immediate actions that we agreed to take in response to that review, but we've had a working group of clinical leaders and operational leaders who have taken the opportunity to stretch themselves and look wider than what the CQC were expecting from us. So an example being, I'll use restricted items again, we immediately put in a monitoring system to ensure that we could control restricted items into our wards. Over in Shropshire, the clinicians said, working with digital, wouldn't it be good if we had a digital solution to this so that we're not reliant on a piece of paper or a member of staff? So they are piloting a digital solution to managing how we keep people safe and take those at-risk items from service users when they're entering the ward. That wasn't a requirement of the CQC, but it's an innovation that's linked to it, hence why we've associated it with that action plan.
Thank you, Liz. That's very comprehensive and assuring us in terms of some of the challenges that you're addressing. Debbie, if I can bring you in.
Jackie, does Abid want to reply to that particular, because mine is a different question.
It's fine if you go ahead, thank you.
Okay. Les, my question is I suppose more again about the system piece, and we alluded to it in both the last meeting of the Quality and Safety and in Integrated Business and Performance, and we've set out very clearly the financial challenges that are facing the system next year. Each organisation will be looking to deliver its cost improvement and do all sorts of things to close that financial gap. And the piece that worries me is not our internal quality assurance piece around the impact assessments. The question, do we have a mechanism to do that effectively at a system level? Because what we don't want to see is either through our work or others that we have unintended consequences and impact on our own services, yes, or others. Yeah. Thank you.
So I think I would say we've got a developing process across our systems. Each of the providers have their own internal quality and their quality impact processes. Those are coming together now at system level, both in our local systems, but also in our specialist services as well, that Howard obviously has a great deal of knowledge of. So would I say we're completely aligned? No, not yet, but actually we've got an established mechanism for doing that with a group that oversees that, and obviously some of that feeds both into the quality and safety committees at system level, but also will feed into the performance and finance and business committees within our systems. The very big ticket items that have an impact across multiple layers, yes, we do have those conversations. And the other thing, as you'll know, we're starting to do and have done successfully, particularly through John Costello from our QI team, is undertake system-wide pieces of QI work, which is helping us to achieve that financial ask, but at the same time improving efficiency and improving quality. So yes, I think that's my honest answer in terms of where we're at this moment in time.
Thanks, Jackie. Thanks.
Thank you, Liz. Thank you. Abid, you had your hand up.
Thanks, Jackie. I was just going to support what Liz is saying in terms of the continuation of audits. A weekly audit is done. Each ward has a ward clerk, and it's their responsibility to do a number of parameters that are important to the ward and escalate it to the matron. So there's a system, and it's like a tablecloth. It's all green, and there's red stands out like a sore thumb. And they just, when they send the audit, they said, please complete these actions by 48 hours or something like that, so that when the report goes out, they're all done.
Thank you. Thank you. Thanks for the clarity and assurance. I think that's really, really welcome. Liz, I just had one question around the learning from deaths in terms of the culture of the organisation, how we embed the learning and how we kind of assess across areas that learning's shared across other areas.
Yeah, so absolutely. So we have forums where we come together with the clinical and care directors and the clinical experts to discuss and agree how we're going to impart learning, dependent on what the learning is. We have a learning the lessons bulletin that we cascade across the organisation as well. And where the specific learning that it's important that we take action, then obviously we take that directly either through those operational management routes or down through the quality and safety routes through the clinical and care directors. We've also got some plans to do some learning the lesson events
Okay.
so that we can do, and we're planning to do those virtually, so as we can get to more members of the organisation than if we held an in-person event. So it'd be a focus on a particular area of learning, with an opportunity not just to cascade the learning, but for some clinical discussion and debate about how we might further enhance services. So yeah, there's multiple layers of it,
Okay.
some which are quite specific about taking action, but other that are more of a cascade and an awareness building.
Okay, thank you. And again, Liz, I can't see any further hands up or comments, but I just think thank you for answering some of the kind of assurance questions people have raised. Quite, and I recognise the good work that our clinical and nursing teams are doing in terms of making that difference. And particularly, I think what's refreshing is the CQC feedback from the recent report as well. We can see that some real good examples, and I think we need to share and feedback that to staff as we move forward, because I think given what's happened in the past, it's that morale in terms of what people are doing really well. So thank you.
Jackie, could I just say, because I think it's important to note for those clinical teams, inpatient teams, that obviously, acuity has been high. There's been many challenges across the inpatient footprint, as there has across the whole of our organisation. But I would just say that those clinical leaders and all the staff on those wards have embraced this CQC report. And I didn't see a huge dip in morale. What I saw was a group of staff that embraced what was being told of them and worked together to implement change. So I think it's a credit, and it does go back to what we say about the culture of this organisation, even though around them is lots of challenge and lots of acuity and demand.
Yeah, I think, again, I can see lots of hearts and claps. That is really positive. And I know myself and Neil visited those areas after that report, and what we saw was that kind of positive, we can do this, we can turn this round, and I think that's to be commended. But I think we just need to keep the morale going. It's a really, they are really important to making us as good as we can be. So yeah, thank you. So I'm going to move on now to the compliance and regulatory part of the agenda. So we have the eliminating mixed sex accommodation declaration, and Liz, that's again another item for yourself. I don't know whether you want to give us a highlight and intro and context around this again before we go through the approval process.
As briefly as I can, and actually it does link into the CQC inspection reports as well, because mixed sex or single sex accommodation in particularly in mental health service areas is something that's always in the eye of the media. It's something that the CQC look at very closely. What I wanted to just say is this compliance declaration, which does demonstrate compliance, is quite clearly against those national parameters that we are required to comply with, which are stated on page 73 of the pack of papers. So what it's saying is that whilst in some situations single sex is the preferred option, that it's not expecting that all organisations make all of their wards single sex wards, but there are certain conditions under which you need to operate to maintain the safety of vulnerable individuals in a mixed sex environment. And for us, we can demonstrate that we have complied with that throughout 2023 and that we've had no breaches of those national requirements. The CQC element of that is obviously picking up some of the challenges of managing admissions into busy ward environments and having to place people of the opposite gender on a corridor which is dedicated to either male or female. When we do that, and we've got ensuite bathroom facilities, that is in compliance with this guidance, so we're not breaching. But obviously what we have to do, and we do as an organisation, is risk assess the appropriateness of that for each individual and put in additional measures to safeguard individuals under those circumstances. So additional staffing that would undertake additional observations. What we are doing though, just to finish off this piece, is that Sharon Conlon, who's our safeguarding lead, and her team are looking at a review of our inpatient environments through that angle of choice and vulnerability, not through the angle of not meeting this compliance agenda, so that we can ask our service users, so we're doing some service user intervention work, and ask our staff about the future of mixed sex wards versus offering some single sex accommodation. The outcome of that work will come back through to DMG, and then we will share it with the board in terms of what that review and position tells us. But from a point of view of meeting the national requirements, we are and continue to remain compliant.
Thank you, Liz. Are there any comments or questions for Liz? Jane?
Thanks, Liz. And I recognise this is national requirement, so it's great to hear about that review on the subtleties around it. And in that respect, I'm aware that the trans policy is currently going through review, and I'm just wondering whether that is part of the review.
It is actually, Jane, and it's a key part of that review, and the challenges of choice, actually. So if we moved to wards that were single sex, we are actually reducing the choice for some of our transgender community. So yes, we've absolutely, and Sharon is engaging with some of our transgender service users to ask those questions about preference and choice in those situations.
Thank you. If we can just make sure there's a link across to the trans policy update, which I think is ongoing, that would be great. Thank you.
Yeah, thank you. A good question. I was going to raise that, so really positive. So thank you, Simon.
Yeah, thank you, Liz. And actually, Liz, I think you've certainly touched on my question, almost answered it. But you talked about when admitting patients to a mixed sex corridor, we have to do risk assessments and then enhanced staff observations. How do we get assurance that that programme of increased observations is actually being carried out and continuously carried out?
Yeah, so actually through the ward reviews, so when they're actually reviewing individual patients through the multidisciplinary review process, because we record the observations, so we've got a record of that. Obviously through speaking to the service user in terms of them feeling safe and then feeling, you know, that's an appropriate way to manage them. And then we do audits as well, so we've got multiple layers again of assuring ourselves. But for me, the key bits are the individual patient reviews, and where we can do and where it's appropriate, if we do place somebody on the opposite corridor, when there is an appropriateness, we will move them back across into that corridor. And if there are any vulnerabilities through that risk assessment, we wouldn't place them in that environment. We would absolutely put them in that single sex or in the female corridor. We don't have mixed sex corridors. We do have single sex corridors. It's just that sometimes we have to use the beds that are closest to the lounge area if we've got more patients of a certain gender that we need to accommodate on the ward. But yeah, those reviews happen daily actually around those patients.
Thank you, Liz. That's very reassuring. Thank you.
Thank you, Liz. Thanks for the clarity. Neil?
Thanks, Jackie. I think board members might like to be cited on the fact that key execs from all of the mental health providers in the West Midlands met over the last couple of months. And we talked about various issues. One of the issues was beds and how we're using beds and some of the issues. And as you'll know, given the acuity of patients, often patients are having to go out of county. And one of the things I believe we need to do is look within the West Midlands how we can collaborate far more effectively on the use of beds. A good example would be here in Staffordshire, there are probably enough male intensive care beds, not enough female intensive care beds. But if we could collaborate in a different way, we could provide a very safe environment for our patients from a sexual safety perspective, just as one example. So that's work that is now launching, and people like Mel Watson and others I hope we'll be very close to that. The Chief Operating Officer in Birmingham and Solihull I spoke to on Tuesday evening about the issues, and I'm going to chair that group. So I'm quite excited that we will not only be able to comply as we do, but ultimately as a wider system help ourselves a little more effectively if we can work with beds in different ways across the whole system.
Thank you, Neil. And the next hand I've got up is Chris.
Thanks, Jackie. It's just an observation going back to the assurance piece, because it looks as though we've got the controls in place. It looks as though we're auditing our controls. The things that I've not heard about is whether we're getting any external assurance on the process we got in place. And this is quite a high risk area, isn't it? I just wondered whether there was any scope for maybe on a 3-year rolling cycle, whether we get somebody in, whether that might be a peer review with colleagues from other organisations, because I think you get set in your views when you're looking at things internally. It's just nice to get a different perspective because things do move on.
And I think it's a really good point, Chris. We have done that previously, actually, and we've had through our what would have been the CCGs, now the ICBs, through our safeguarding teams, we have had reviews of our inpatient facilities before around this area of mixed sex, single sex accommodation. So we've had a team that have come in and visited us, which did not only just include our ICB or CCG colleagues, but also we had experts by experience as well as part of that. I think for us as well, we've had CQC reviews across our mental health inpatient estate now, haven't we, through the acute and older people. So we've had that external review through that lens. We possibly need to consider our physical health inpatient estate, so our services at the Haywood Hospital, because obviously this does apply to them as well as our mental health group. So I think it's a really good point, Chris, and yes, there are peer review teams who would offer that to us actually on the basis that our particularly through safeguarding, and our safeguarding experts often join those peer reviews as well.
Can you just come back on that one? So I would like to see something independent of CQC, because although CQC will provide external assurance, I'd like us to do that before they actually come in and do that report. So I just wonder whether that's something we could consider then.
Can we take that as an action then, Liz, for something that you can scope? Because I think it's an important, and I think it's a really appropriate suggestion, because it actually enables us to actually check ourselves before the CQC come from an assurance point of view. So I think that is an action that hopefully you could take on and follow through. Yeah, thank you, Chris. Thank you, Kathy.
Just to quickly add to the board, because apart from things that Liz mentioned, which are really important around assurance, we also address it with service users when they get admitted to wards. So sexual safety is explicitly described in the welcome pack, and the issuing of personal alarms and things. So this is something that if people are feeling nervous or anxious around, it can be addressed because it's explicitly stated and covered in that welcome to the wards.
Thank you. Are there any further comments, questions for this? So I can't see any other hands up, but this is here because we are asking the board support, because it's key for the trust declaration in compliance in terms of delivering the accommodation. So again, it's just broadly asking that we all are in support of this. Yeah, and I can see lots of nods of heads. It's a statutory requirement, but again, Liz will take away that action in terms of external review. So thank you. So we all support that, and that will go forward. Thank you. The next item on the agenda is looking at our kind of element around strategic or business critical issues, and we've got Helen Slater here, I believe, from the ICB, really to take us through. So a warm welcome, Helen. It's good to have you here today. So thank you.
Thank you. I'm also joined by Nikki Bromwich as well from the ICB today. So I've got a couple of slides, if I can share those with you and just talk you through the stages of the process that we've just recently undertaken. So I'll just those. Can you all see those?
Yes.
Yes. Okay. So for those of you that don't know me, I'm Helen Slater. I'm Associate Director of Transformation, and I've been working with colleagues across the Trust and within the ICB to lead the process for the long-term solution for inpatient mental health services previously provided at the George Bryan Centre. So Steve Grange as SRO for the programme has led this steering group, and a number of colleagues have been involved with both the clinical processes and the consultation process that we undertook last year. So just in terms of, just as a reminder, the options appraisal process was undertaken, started prior to COVID, and was picked up after the pause for COVID. Apologies, somebody's just knocked the door, so that started the apologies. But we went through a process in terms of the options appraisal, and through the steering group and feedback from pre-consultation engagement, the decision was made in terms of moving forward with one proposal, and that was to make permanent the temporary change and maintain the inpatient mental health services at St George's Hospital that had been put in place since 2019, supported by the 2 enhanced community service offers for both dementia care and for severe mental illness. Through this process, we updated the clinical model, and we had assurance through the West Midlands Clinical Senate to demonstrate how that clinical model aligned with national and local policy. We looked at the workforce and the clinical safety issues of that model, and we also sought legal advice in terms of moving forward with one proposal through to consultation process. We also reviewed the finances in terms of any capital resource required and whether there was any impact on system revenue. Through that process, we continually updated our engagement process and went out to consultation last February for 6 weeks. The report of findings from the consultation was taken back through our steering group, and the impact of that report was discussed within that group, and it was deemed that there was no new proposals that had come forward through that consultation process. However, there were some clinical areas and some areas of support for carers that we wanted to take into consideration when we were reviewing the impact assessments. So some of those areas included the impact of travel for families and carers to visit patients at the inpatient site at St George's, some of the digital solutions and work building upon the digital solutions that you already had in place to support virtual visiting, but also to look at the impact and the information for carers, particularly for those with dementia, who may receive a huge amount of information upon diagnosis, but might not need that information until further down the line in their pathway. So that was some of the impacts that we took into consideration. All of that was included within the decision-making business case. That went through our governance process in autumn last year. So we had to pause some of that because of the pre-election period in Tamworth, and the decision-making business case was taken to the ICB board on the 21st of December. So the board reviewed that decision-making business case, had an open and honest conversation in terms of the findings from the consultation, and took into consideration the recommendations within the document itself. One of the recommendations that came through was picking up the monitoring of the service going forward, and there was a recommendation from the board that in agreeing to make permanent the service change, that the impact of the service would be monitored, and that would go back through from the organisation through to the Mental Health, Learning Disability and Autism Portfolio Board, and subsequently through to the Quality Safety Committee and then through to the ICB board. So that would be undertaken at the back end of this year as part of that agreement to approve the recommendation. There was also recommendations as we went through the Quality and Safety Committee and the QIA process in terms of making sure that people's rights to family life are not impeded in terms of the travel impact. And that's part of that monitoring element in terms of offering that financial support and that digital support to people who may not be able to access visiting at the site. We also wanted to ensure that as the services develop through the mental health transformation programme and as new services come online, that information is cascaded to the local population across the South East area. And there was also a request in terms of keeping the population updated in terms of the development of the Cherry Orchard unit and what services would be offered there. So in conclusion, the decision did agree to make permanent the temporary service changes that have been in place since 2019, with the caveat that reporting would take place. That's my summary to you. Happy to take any questions.
Thank you, Helen. Thank you for taking us through that. Are there any comments, questions from colleagues here today? Abid?
Thank you, Helen. That very succinct presentation. Thank you very much. I don't underestimate the task of consultation and how we went to various locations to give. I just wanted to acknowledge Lisa Gell's contribution to this, because she handled all the difficult questions, really. So she had one-to-one when questions were raised and concerns, and she was a huge resource during the consultation. But I note that in your presentation, you have addressed the issue that was most commonly raised about the distance and the travel concerns of the local population. Thank you.
Thank you. Helen, did you want to comment or?
Yeah, Lisa was absolutely fantastic in responding to some of the questions, and through the consultation we had a range of face-to-face sessions and also online events. There was the online survey as well, but through some of those events and through the sessions that we held in places like the entrance to Asda in Tamworth, etc., Lisa would follow up with some of those, as did Nikki and other members of the team, in terms of being able to respond to people on those individual queries that they had. And we recognised that through, there was a strength of feeling in terms of, the proposal that we were putting forward. But we dealt with that with compassion. But the team also, through Steve and others, also had support for those people that facilitated the consultation as well, because some of the feedback did have impact on individual members as well. And through your organisation, you supported people from the comms and engagement team, from the transformation team and from the mental health team themselves in terms of supporting with some of the feedback that they heard through the consultation. So thank you for that as well.
Thank you. Neil, can I bring you in?
Thanks very much indeed. I'm sure board members will remember, but this has been said 4 years ago plus, and we've been operating a different model since. I would argue a more contemporary model and a model more commensurate with keeping people in their own homes and in their communities, but if inpatient care should be needed, that we could provide it. So I think what's important to me is we recognise this is better practice, this is contemporary practice, this is about wrapping services around people in their own communities, with beds being a last option. But Milford Wood on the St George's site facilitates people from East Staps if they do need inpatient care. Thank you.
Thank you, Neil. Thank you. Simon?
Yes, thank you, Jackie, and thank you, Helen. And this question may actually be more for my MPFT colleagues rather than for you, but I was interested in the recommendations about ensuring service users and carers know how to access services and work we're going to have to do to do that. So will we have to do, and what sort of extra work will we have to do? And in a sense, does that differ from the sort of work we do anyway around the county to ensure that people wherever are able to access our services. So I was just interested to know what you have in mind to meet that recommendation.
So some of the feedback was mixed in terms of those people that have never used the service before and those that have used the service, but also those, as I mentioned, in terms of the carers who take on a wealth of information at the early stage of following a diagnosis, and it's how we maintain that. But through the decision-making business case, we were able to articulate how some of those communication updates are supported. But I think it's as we develop new services and localise them more, it's about making sure that people are clear. I know that you keep a wealth of information on the website, but for some people, they wouldn't know which organisation runs the local services. So it's making sure that it's easy accessible in different points across. Nikki might want to pick up in terms of some of the elements that have been picked up through the mental health portfolio to support this as well.
Thank you. Do you want me to bring Nikki in? Hi, Nikki.
Hi everybody. I'm Nikki Bromage, Associate Director for Mental Health LDA and CYP for the ICB. As part of the model of transformation that we've been delivering, making sure service users and carers get ready access to mental health services is one of the key drivers, and having as many multiple access points in the community is part of what we're providing. So that ranges from everything from making sure that the talking therapies services are promoted right through to crisis care. And one of the things that we heard quite a lot in the consultation was around potentially people becoming newly unwell, but that perhaps haven't had any services before, not quite knowing where to go. And that's one of the reasons that we're implementing NHS 111 option 2, so that which will obviously be publicly sort of promoted over the next sort of 12 months, so that obviously we're giving parity of esteem for mental health service users alongside those with physical health issues, that they can go through that number and then get the appropriate response from our provider like MPFT. So we've got lots of initiatives in place that are aimed at making sure that our services are available at the earliest opportunity possible, and that those are sort of promoted heavily within the community.
Thank you.
Thank you.
Thank you.
Thank you.
Thank you, Nikki. Steve?
Thank you. Morning, everyone.
Morning.
I think there's a bit of a process thing next, and I think this is that, it's been quite a long time since we've been working around this, and it's been quite a challenging process, interrupted by COVID, of course, and a lot of other things that we've had to manage along this particular journey. We'll be doing a project overview, closure and benefit realisation, which will come back through our governance arrangements, and then we'll be able to look at all of the other areas around additional support and making sure that the levels of assurance that we've got in place that Nikki and Helen have talked about are there and are being deployed, and that will form part of the latter part of this particular piece of work, this programme. I think it's worth saying, Chair, that I think Abid said it before. Lisa has been fantastic through this process. I'm very passionate about this being a clinically led piece of work. This was all about the pathway and the safety of patients, and the efficacy of how we were doing our support for local people. The other person I think it's worthy to note who spent a huge amount of personal energy and emotion around this is Upkar Jeeta, who's done a lot of work with the programme stuff. But it would be horribly remiss of me to actually not say thank you to Helen and to Nikki from the ICB, because without you guys, navigating this process would have been 10 times harder. And this has not been an easy process to navigate, with government changes, ICB changes, CCG changes, etc., etc. So I wanted to say a very big thank you to Nikki and to Helen, particularly Helen, for being patient along the way when things have been a bit bumpy as well. So thank you.
Thank you, Steve. So, Steve, just a question before I move on to Abid. Are you saying that as part of the project closure, your team will be looking at some of the monitoring as well, in terms of one of the recommendations that we've been given, and that monitoring and feedback through the mental health LD&A programme? Yeah.
Yes, and then through and into the care group, Chair. So I think the
what we want to do now is make sure that all of the things that we said are in train will continue to be deployed. All of the areas that we know we were working on that were priority get closed down, and we'll do that proper project closure and that proper benefit realization that not many organizations tend to do these days, to really understand if we've got any other gaps and then lock those into business as usual. But we'll then be handing that over to business as usual with the care group, and then Nikki, Helen, I guess we'll be linking any other stuff around that into the mental health programme board.
Okay, that's really important though. Thank you. Thanks for the assurance. Abid?
I just wanted to say to Simon, really, in terms of, the question he asked, we have been working with ICB for quite a long time, particularly in their role as commissioners, to strengthen the services in the community. And that really is about having a responsive crisis service, having a liaison service in Queen's Hospital, Burton, which is consultant-led with a team, so we can pick up people with mental health issues, and also promotion of single point of access and digitalization. I think there's lots of pieces of things that have come together to support the community, and so then their needs are still being met in spite of the closure of George Bryan.
Thank you.
Thank you, David. Thank you.
Thank you. Martin, if you've got your hand up, I can invite you to ask a question or comment. Thank you.
Yeah, thank you. Just to second just the final comments from Abid's update, really, just around that digitalisation piece. There's a lot of work in our digital programme, which is really accelerating how we can improve the access and awareness for service users and carers. Most notably of late is the Patient Knows Best application, where the service user carers can get access to their information and appointments through the NHS app. And we're doing obviously a lot of outreach with our digital angels and work in the communities. But I think one of the areas that we can work to do is look at, with Steve's team, some of the localities that have benefited from those schemes, and see, the postcodes and the areas of uptake in those areas as well. So that's something which we can look into. But existing pieces of work with digital are really working quite well, I think, in this space.
Excellent, excellent. Thanks for the assurance. Just as we bring this to a close, I just wanted to thank Helen and Nikki for coming today and just presenting the outcome to us, but also in terms of those involved, like Lisa Agel, Cargita, for all the work that they've done to drive this forward. But I think this is a really important move because it is around modernising and making healthcare much better for our service users, and also in terms of making that pathway better for local people as well, which is at the heart of this decision. It's about improving care and improving experience of people using our services. So I think a major good, and thank you. Thanks for everyone involved. Thank you.
Thank you.
Thank you. Thank you. Okay, so I think we're running well to time, well, just slightly above out of time. I'm just going to take the care group reports now. We've got the first one, the Staffordshire care group report.
Thank you, Jackie. Yeah, thank you. So I'll take the report as read, and we've touched on quite a lot of the items that I've put in here already as we've gone through the meeting. Just a couple of areas that was going to flag. One is just since the report is written, we're obviously in the throes of winter. We have seen winter pressures escalate through January. So both Neil and I have been on a number of calls in terms of the ambulance holes we've got and some of the pressures we've got. That is meaning that we're seeing quite significant pressures into D2A. So the Home First caseload has gone up significantly. We're managing to sustain flow out of the hospital through Home First, and we've had a significant increase in the bed demand as well. So we are working with partners in terms of maintaining flow through that patients, but as it stands today, we do have quite a few patients across hospitals in Staffordshire that are waiting D2A beds, but we're working collectively on solutions around that. And I'd just like to recognise the pressure that puts on teams who take this very personally in terms of getting patients to the right destination to meet their needs, and both the emotional and the physical effort that goes into meeting the demand that's coming through. Just to touch on, we've obviously just talked about George Bryan Centre. I have included in my report one of the areas linked to how we improve access to services is the opening of the Crisis Cafe in Stafford. that has been quite challenging in terms of identifying a suitable location to deliver that service from. We have now identified a property. We're working with the landlord in terms of securing that, but it does mean we would like to look at needing to push the capital funding arrangements for that into next financial year. So working with the finance team and NHS England in terms of being able to do that. I was just going to flag in terms of a good news story that we've been recruiting GPs into a number of our services. So we've successfully appointed into a role at Hayward Hospital covering discharge to assess. So a GP who will be joining us to provide clinical leadership across those services, and also 2 GPs that are joining us in the Staying Well service. We had really good response to the adverts that we put out. So those who weren't successful, we're exploring other opportunities in terms of how we can bring them into community services, and really starting to build that medical infrastructure across our community services. So along with our heart failure consultant that's joined us, I think we've got some real opportunities there. I updated the last meeting. There was a piece in my report around the deep dive that we'd done into assaults and threats and verbal abuse to staff, that particularly picked up an EDI element, so discriminatory comments that were made and particular staff being targeted. Just to let you know that from that, there is a working group that's been set up led by Baz Cottle that's looking at actually how do we understand the reporting around that, because we know we've got some under-reporting of those incidents, what staff support we need to put in place, and anything else we need to do in terms of addressing the underlying causes to those incidents. And that's work that's taking place across the organisation. So just to confirm that we are progressing that. And then the only thing I was going to come to Jo, if there's anything else she wanted to add from an adult social care perspective before I take it out for any questions.
Thank you, Jenny. I think I just echo those pressures around winter and D2A. So obviously that's having an impact, isn't it, on social work assessments. And we're continuing to see increased demand through the AMP rota, which is really quite challenging to manage. But we are working with colleagues in the local authority to ensure that we have got robust arrangements around that. But we are continuing to see that increased demand. Thank you.
Thank you. Thank you. Are you both happy to take any comments, questions? Okay, any comments or questions for Jo? Okay, got quite a few, Jo and Jenny. So, the first person I've got, Simon, you've got your hand up.
Thank you, Jackie. Thank you, Jenny, for good advantage. Can you just explain a little bit more about the risks associated with the demobilisation of EDDI and the Alliance Medical contract?
Yes, so in terms of EDDI, so basically the services that we deliver at the walk-in centre and MIU operate off UH&M's clinical systems, and as part of that there's a national switch off of EDDI, which basically allows us to book people in for appointments at the walk-in centre and MIU. So Martin's heavily involved in this in terms of the mitigations. We had confirmation, I think it was yesterday, that there is a national extension of that system until the end of July. But if we don't seek a solution, basically it impacts on our ability to designate Hayward as an urgent treatment centre as part of the application for that. It'll impact on the ED performance for UH&M because that activity is counted through the system, but also our ability to book patients in through 111. So with Martin's support, we're actively looking at what solutions we can put in place once that system's turned off. UH&M have confirmed they're not looking to procure something as an alternative. So it leaves us quite isolated as an organisation in terms of identifying a solution. Having said that, we're not on our own with this. It is a national issue that a number of services that are going to be impacted by. But I don't know, Martin, there's anything you want to add to that?
Yeah, are you okay? Just briefly.
Yes, please.
So
yeah.
We've found prospective solutions. We've trialled them with the service leads at the Hayward Hospital, and we're looking like there's a viable option that we could deploy even potentially before the original cut-off date of the end of March, and well within the cut-off date at the end of July if we can afford the solution. So that'll be the next step, and we'll take that through the Integrated Business Performance Committee next month.
And then the Alliance Medical is basically we have a contractor that delivers the MRI scanning across Cannock that we subcontract to, but also the ICB contract that is withdrawing from that contract. So effectively looking at
alternative provision to meet those needs. So it's mainly patients that come through our MSK services, but we do also have dementia patients that are under assessment for dementia that come through that provision. It looks like we've hopefully got an alternative solution with one of the existing providers in the system, but we're working through it with the ICB in terms of securing that. So just a risk that we've got at the moment.
Okay, thank you, Jenny. Thanks for the assurance.
Thank you, Jenny.
Simi?
Thank you, Jack. Hi. Thank you, Jackie. Just a question about ADHD services, Jenny. Given that we know that's a risk around capacity and demand, are we looking at mitigations, horizon scanning options, considering impact on patients and also the trust?
Yeah, so there's work we're doing with the ICB in terms of the demand that's coming through and how we can meet that demand. There's also work we're doing across the organisation in terms of neurodiversity as a whole. So how do we better meet those needs from both an assessment and treatment perspective in for neurodiversity for children and for adults. So Ben Rogers is leading that work, so that's part of contributing to that. But in terms of the sort of short-term mitigations, we're working with the ICB as to how we can meet the need against the demand that's coming through. The biggest risk we've got really is in terms of workforce and then the financial pressures that brings.
Okay, thank you.
Thank you. Debbie?
Yes, thanks. And thanks, Joe and Jenny. My question was just about the demand for AMPs, and I don't want to rehearse lots of conversations that have gone on in quality and safety committee about it. I just was wondering, Joe, I mean, I don't think we are clear what's driving the demand because it isn't being seen in Shropshire, Telford and Wrekin. And my understanding is that not a lot of these, that they're not converting into Mental Health Act detention. So it's kind of demand that's coming your way, really. And so my first question is it resulting in increased restrictive options if patients are then defaulting into A&E? And is there anything that collaboratively we can do to, to try to take that demand somewhere else, if that's an option?
So I think in terms of the first question, no, I don't think it is resulting in more restrictive situations for people. We've done quite a lot of work around this, to be honest, and we have got quite a detailed report around our findings, which is talking about the sort of people who we're seeing through Mental Health Act assessments and the outcomes, which I'm quite happy to share with the board if that would be useful. But what we're seeing is exactly what you've described, Debbie, really, is we're getting lots of demand, but actually the AMP is able to identify alternatives in the community, which are those least restrictive options. So in some ways that's a positive story, but actually we're tying a really, really sort of skilled resource up where probably we don't need to. So we have got a system-wide meeting in a couple of weeks' time, really to try and sort of explore options. It's primarily around Section 117 because we're seeing real increases in the number of people with an entitlement to Section 117. But as part of that, we're going to look at that whole admission avoidance agenda and what we can do better as a system to really address these issues. So we have got that in hand, and I should be in a position to update in March's board around that.
Thank you.
Thanks very much, Jackie and Joe.
Joe, I think it'd be useful if in the update report for March, if you can just really highlight progress of that and the actions against that. So that'd be helpful. Thank you. Okay, the next hand I've got up is Liz. Hi.
Yeah, it was only just to add to that really about the ongoing dialogue, particularly with partners, but particularly with the police around the right care, right person model and the importance of getting it right there, because what we don't want to do is increase demand because of those changes. So just to assure that across both local systems, Shropshire and Staffordshire, we are through the care groups and through Dawn Crowd and myself involved in working closely with the police and with other partners around making sure we're getting it right for those individuals who historically might have gone through that police route and had police intervention, because that does have the potential to increase the demand on our AMPs.
Thank you. Did you want to come back to that, Jenny, or you're quite happy with the comment? Okay.
No, it's nothing else to add.
Okay, is there anything else anyone wanted to add before we move on to the next report? Okay, I can't see any hands up. So the next I have on the agenda is the Shropshire, Telford, Wrekin Care Group report. So Kathy, hi.
Hi, please take the report as read. There were just a couple of things that I wanted to highlight. One that we've seen from some low-level concerns, but also complaints arise for people associated with autism. And so we're sort of looking at that towards our delivery plan for next year. We have increased, and in fact doubled the capacity that we have to deliver autism training from a person with lived experience. It's been doing it for a number of years, but probably not with the capacity that we need. So we've increased that. We're also looking in terms of our audit forward plan around it, looking at an audit against the new guidance that's come out for people with autism in mental health services, and also linking to the work that Ben is leading across the trust. So that was one thing I wanted to raise, and the other one was just to escalate and make you aware of the staff wellbeing hub. We've got funding that continues until October. We have about 500 referrals a year, but we are seeing an increasing pattern of referrals which come from all the organisations in Shropshire, Telford and Wrekin system, and we do need to secure funding for it to continue, because nationally that funding is going to be discontinued. And I know that Chris has linked into Claire Skidmore in the Shropshire, Telford and Wrekin system, and it will need to go through the investment process unless we can beforehand come to agreement with the various organisations to contribute towards it. I just wanted to make the board aware of that as a potential risk to the future at system level.
Thank you. Thank you, Kathy. Are there any comments, questions for Kathy? Mark, can I bring you in?
Just a quick one. Concerns over the fire evacuation training. How quickly, I see there's on-site training, additional training being arranged. How quickly do we think that one will be resolved?
It's already resolving, Mark.
Fantastic.
I mean, it was because we did a lot of work at about 12 months ago, and so suddenly it all dropped at the same time, and we need to be mindful of that this year. So through Liz's team, we've got additional capacity there for the training. The compliance rate's already going up quickly, and we just need to do in the course of this year make sure we stagger it so they don't all lose the compliance at the same time again.
Brilliant, thank you.
Thanks for the assurance. And another hand up, Alex, can I bring you in?
Yeah, thank you, Jackie. Thanks, Kathy, for raising that around the hub. And just to make the board aware, I think the board is aware we've got the same issue in Staffs and Stoke-on-Trent as well. So two pressing issues, huge numbers of staff going through both of those hubs with, obviously, as Kathy's described, the funding coming to an end. So we're doing a similar process in Staffs and Stoke-on-Trent, but we will have to bring that through back to People Committee for a live conversation in the round once we know what the position is. But time is pressing and time is running out, as Kathy's described. So would seek your support in that space when we get to that wider discussion. Thank you.
Thank you, Alex. Thank you. One question for me was around sharing of the learning around the assaults on wards. Kathy, I don't know whether you could just give some context to that.
So there is a learning review that's been done and the actions are being shared. So we have a huddle as well that happens across all band settings on the ward. So any learning around things like that get fed through to that huddle, Jackie.
Okay. And that learning, is that being fed back through the review, but not just to that ward area, but sharing with other wards where?
Yes.
Yeah. Okay. Thank you. Just to thank you, Kathy, for taking us through your report, and thanks for the assurance that you've provided. The next report I've got is the Children and Families Care Group report. So if I bring Claire in to just take us through the headlines.
Thank you, Chair. So we picked up audiology earlier. So the other 2 points I just wanted to pull out of the report this morning were with regards to routine health assessment and then the CAMS risk. So routine health assessments, they're the assessments that are done for children who are looked after. And you'll recall from previous reports that we've got backlogs in this service, and that's down to increasing prevalence, increasing demand, and the capacity of the team to meet that demand. We're really pleased to say that we've got additional funding so that we can progress to not only have a waiting list initiative, but to increase the baseline staffing of that team. Of course, that's going to take time for us to work through that backlog, and the risk associated with that is recruiting the staff. We've got a good onboarding process and an induction process, but of course it's getting the workforce in place. But I can continue to update that, but it's a really important step in terms of us being able to provide a better offer for those very vulnerable children within our communities. And the second point then around CAMS, you'll note on there that CAMS was a de-escalating risk. And again, I'm really pleased to say that because of the efforts of the team and the immediate leadership of those teams, that we're recommending from a care group perspective that the risk is further de-escalated. So that will go through the appropriate governance. But we held that review meeting as a care group earlier this week. And we will continue to monitor that risk, because we're advising it's reduced to a 12, so that still means it's on our risk register. It's still subject to our review through our governance, and we will be monitoring that service closely. But in addition to that, we're also going to do some learning with the team and reflections, because they've managed this really well. We can see that that's been through some visibility, shared problem solving, changes some of the culture within the team, and then the sheer hard work and innovation of the staff in the team. So we do want to do some learning so we can pinpoint and apply that learning to our other areas of increasing demand or where we have waiting lists. So those are two key things I just wanted to pull out. Thank you.
Thank you, Claire. Thanks for the conciseness. Are there any comments or questions for Claire regarding her report and update? Okay. Okay, I can't see any hands up, but just wanted to thank you, Claire, because I think the routine health assessments for looked after children has been a great challenge over the years. So I think to actually have come to some solutions to address it is really positive. I just wanted to just check, when we're likely to see some changes as a result of that?
So the plan that we've got in place to reduce that backlog based on the staffing could be up to 9 months. So we're looking at January, and that of course depends when we can get that capacity in place. The team already prioritise the children. So for example, if children are awaiting court proceedings, adoptions, etc., then there's already that prioritisation to make sure that the backlog doesn't delay any of future opportunity around children placements. But the waiting list initiative will take up to 9 months.
Thank you, thank you, thank you. I'm sure it'd be proactively managed as well during that period, I guess. Yeah. Okay.
Absolutely, and given the risk on the risk register, it's also subject to the care group's risk and performance meetings that we hold monthly, so that we have that additional space and time to really scrutinise any progress, any risks, any escalations, and just get that assurance. So those will continue, Jackie. And of course, we're working with the ICB on this. This RHAs is something that's on their risk register at a 16, and we'll also be working with the local authorities from Stoke and the Staffordshire County Council perspective.
Thank you. Thanks for the assurance. Thank you. Thank you. I'll just move on to the last care group report. Howard, for the specialist care group, if you could just take us through any highlights, exceptions for that. Thank you.
I can try to. Unfortunately, my computer's crashed, so I can't actually see anything at the moment. So,
I can see you.
if I assume that the report is taken as read, and rather than try and go through things I can't see, if there's any questions, happy to take them.
Okay, thank you. Thank you. Are there any comments or questions for Howard? Debbie?
Thanks, Howard. I'm sorry I'm asking, well, I hope it's not a difficult question when your computer's on the break. It was just about the transfer of the Staffordshire Drug and Alcohol Service, and we had an update at Integrated Business and Performance Committee, a verbal one. I suppose I just wanted to question, public consultation, is there a formal public consultation then regarding the transfer of this service? Because I don't think I picked that up.
There was. It was completed over the Christmas period, so they've had the feedback from I think about 280 people, and it was over 95% positive about the proposal.
Oh, that's fine. And I suppose just I think we received assurance that the kind of due diligence would, be going. Will the outcome of any of that be reported probably through integrated business and performance or up through board when we know the outcome?
It can be. We've got the report actually, so I'm happy to share that. Happy to share that so you can see what we said.
Brilliant. Thank you very. Thanks, Jackie.
Thank you. Thanks, Howard, for agreeing to share the report as well. Okay, another question or comment from Jane. Hi, Jane.
Hi, Howard. It's great to see the list of renewals and new services coming on stream over the next couple of months. And I think a credit to the service that the Trust offers in support of service users, where we can make a really real difference in those areas of our expertise. One question you raise is, or one challenge you raise, is around support from corporate services. And I'm just wondering whether that's moved on from this report and what plans are in place to ensure that those mobilisations go well.
There are plans in place. So when we win a new service, there's individual meetings about what we require in terms of support and making sure we're engaging the right corporate services. The reason for mentioning it in the report is it's a challenge, and I think the feedback from those meetings has been a number of corporate teams are experiencing a lot of pressure. They're feeling really quite swamped at the moment in different ways, and taking on even more work is a bit of a struggle for them. We're confident we can take it forward, but it was, I think, for the report, it was worth highlighting that there's a pressure internally there, and perhaps other people who lead those teams might want to comment on that.
Are there any particular areas that you're concerned around, particular skills or gaps, Howard?
It's different for the different ones. I mean, the prison ones don't have as big a pressure in some areas. For example, the IM&T support we need for prison contracts is quite small. I think the real pressure points are around some of those community mobilisations, and, to be fair, the demobilisation in Thurrock, where we're having to pull in people from estates, workforce, IM&T. We've got information governance things we need to do, and it's getting that done within those timeframes. We've got just over 10 weeks now before we need to go to the next one.
Okay, no, thanks for the alert.
Thank you. Thanks for the alert. If I can move on to Mark, who's got his hand up. So
actually,
Mark,
Jane actually asked the question I was going to ask. Can I? There's a comment I'd like to make, but can I let Alex go first?
Okay, Alex. Thank you.
Yeah, thank you, Mark, for that. And as Howard's invited us in, it's probably worth just a comment and an example, really, Jane. So for the workforce team, it's all of the technical elements around TUPE transfer. It's pressures on the recruitment team around systems and processes, and very often that's not something that you can just hand to someone else or bring someone else in. So it's that element of trying to juggle that short-term programme of work and activity on top of, if you think about the other pressures we've got at the moment, whilst we're in winter, we're opening beds, we're recruiting into different services around growth. And I think it's how do we manage that short-term prioritisation of actually quite technical work that requires expertise on top of everything else that we've got, but we juggle it, and we've always juggled it, as an organisation. We're used to doing this, but it's not without its pressures, as Howard's articulated, and I think is just for us to be aware of and note that we have to balance that with many different competing demands when that business is coming in. Hope that's helpful context.
Thank you. Thanks for the assurance, Alex. Thank you. Mark?
Yeah, I was just going to raise a different point. I think something that's worth highlighting. I'd be interested in the Managing Director's ongoing view about it, is the care portal news. We moved Rio out, so MPFT moved Rio out to the Access Group in the hope of making it more stable. It generally has been, I think, a good step forwards, but there are occasional problems, and the advent of Care Portal means there is a copy of the Rio data available should Rio go down or be performing badly that staff can access, which should remediate any of the issues that staff face whilst they're in front of patients. I'll be interested to know, has anybody resorted to that you know of yet, but ongoing I'd love to understand how well that's working.
Thank you, Mark. Thank you. I don't know if anyone's got any comments or feedback on that from the MDs at all. Kathy?
Just that I don't know, but I will look. I will specifically ask Mark and feedback to you.
Yeah, thank you. Okay, no further hands up or comments. So can I thank you, Howard, and I hope your technology sorts itself out later, for taking us through that and answering our questions and providing assurance. So thank you. I'm going to move on to the next part of the section, which is the committee summary reports. I'm mindful that we're running slightly out of time, but I just wanted to, these are important documents to go through. So if I could invite Simi to just take us through the highlights for the Quality and Safety Committee summary report. Thank you.
Thank you, Jackie. So I'll take the report as read and just go through some highlights. December's committee was not quorate, just due to unforeseen circumstances, and just to assure the board no decisions were made at the committee that required us to be quorate. We've received confirmation that Shropshire Fire and Rescue Services consider the 2 fire enforcement notices that Redwoods has complied with. We've asked for a further detail in relation to the outstanding actions from the 2019 CQC well-led review, and this will come back to committee in April, and very much links into our conversations today about behaviours and being well-led, and we really want to see those clearly defined updates coming to committee so we can monitor those. And just also to highlight that we've got a suicide prevention conference next month, and learnings will be reported back into committee. We've spoken about the board assurance framework. We've spoken about CQC, so I won't go over that again, but happy to take any questions or comments.
Thank you, Simi. Any comments or questions for Simi in terms of Quality and Safety Committee? Okay, so thank you, and thanks for the assurance. In terms of the Integrated Business and Performance Committee summary, if I could ask Debbie to just take us through some exceptions and highlights for that.
Yeah,
thank you.
Thank you, Jackie. I will just take it as read and pick out a couple of points. I'm not going to go through the risk stuff because I think we've had a robust conversation about that, and we have some robust reviews planned over the next couple of months anyway, plus the work that the board will do. I just wanted to advise the board around the UHNM electronic patient record outline business case. This is something that UHNM are leading, but potentially scoping whether there is a system opportunity. We're not committing resource at this point, although there will be some digital capacity to support it, but we're supporting the journey to full business case to really enable the scoping. The caveats are in the paper, and the committee supported us continuing on that journey. The other thing I just wanted to finish off was a positive around the achievements, and the committee noted the excellent financial work of Chris and team. Very much welcome the performance dashboard, and particularly picked out the good progress noted with a significant reduction in out of area beds, mental health beds, which is, I think, Neil, interesting part of that dialogue, and also the diagnostic reporting in children and families audiology, and the system working with continuing care. So that's all I have got to say, unless anybody wants to ask me any questions. Thank you.
Thank you, Debbie. Any comments or questions for Debbie? Thank you. Okay, thank you. And again, you know, it's really positive in terms of the outcome. The team have made a difference in terms of finance reporting, so thank you as well, and well done to Chris and the team. In terms of People and Culture Committee, Pauline, if you could just take us through some highlights for the exception summary report.
Okay, thanks, Jackie.
Thank you.
Just to pick up on the system conversations that we've had, I thought it would be good to provide assurance that People Committee connect with the ICS and ICBs twice a year. So twice a year with Staffordshire, Stoke-on-Trent, twice a year with Shropshire, Telford and Wrekin. So very strong connections there. We have had conversations around the board assurance framework. There is going to be a deep discussion around the appetite of People Committee at our next committee meeting. And some of the conversations that we've also had around consistency across committees, and I know Richard's got this in hand in terms of starting to review that. And in addition to that, really getting to grips with how the governance is working underneath the committees, so there's a clear line of sight. And finally, in terms of achievement, whilst this is from our December report, because we've only just had the meeting last week, in Shropshire, Telford and Wrekin, just to celebrate actually the success that they've had with their recruitment. And I think getting that up to around 90% was really significant. So well done to Kathy and the team.
Thank you.
Chair.
Thank you, Pauline. Thank you. And well done to Kathy and the team in terms of recruitment. That's fantastic news. So thank you. So we've gone through the 3 summary reports. I am just moving on to the end of the agenda. I am aware of any other business, and if I can invite Chris to just take us through what the request is as part of the AOB, that would be great. Thank you.
Thanks, Jackie. So we're just in the process of finalising the charitable fund accounts for this financial year. So I'm asking the board for delegated authority for the audit committee on Monday to sign off those accounts on the board's behalf. The intention is that there'll be an opportunity to look at those at the charitable funds committee tomorrow, and then we'll have the opportunity on Monday. We're just finalising the final bits with the auditors. There are no areas of concern that need to be brought to the attention of the board. It's pretty straightforward.
Thank you, Chris. And again, just to ask the board if we are happy to delegate authority to the Charitable Funds Committee to take this forward. And I can see nods of heads. Yes. So that's approved, Chris. That's fine. Yeah. Thank you.
Thank you.
Thank you. Okay, so we've ended.
Sorry, Jackie, sorry to interrupt, but on that point, you're actually delegating to audit committee, aren't you?
Sorry, we delegated, to charitable committee to discuss it, and then audit committee on Monday in terms of sign off is my understanding. Is that right?
That's correct. Yeah.
Yeah. Thank you. Just wanted to thank everyone today for all their contributions. I think we've had some really good discussion on some key items. Also, for people, there is a reflection form in the MS Teams chat for you to fill in to feedback on this meeting, but just wanted to thank everyone for their contribution. This is the end of the public part of the meeting. We will go into the confidential section at 12:30, so look forward to seeing you all there. Thank you. Take care. Bye-bye.
Thank you.
Bye-bye.
Thank you. Bye.
Thank you. Bye.